So we will see that this is the case 4R restriction was there. This is the superior vena cava, and this is the lung that is being reflected. So then, how will you? And this is the review of the video that we have recorded. And this is the needle that is going in, and this needle is going into reverberation artifact. Virottam, you are ready?
Yeah, we are ready.
Okay. So now Dr. Virottam is getting ready with the next case.
Okay. So good morning, everybody. And it's a beautiful morning. We are celebrating the 75th Independence Day of our country. So heartiest congratulations to all. So in previous, you have seen the very beautiful case, very easy case, which is having large paratracheal lymph node, the 4R, and station 7 lymph node. But this patient is having a little bit difficult case because he's having sequelae, post-COVID sequelae. His whole air saturation is around 86 to 90%. And he's having right upper lobe mass of 3 centimeters spiculated margins and small paratracheal FDG positive lymph nodes. So we will try to look if we can do justice in this patient to take the FNAC from this small paratracheal lymph node or any other lymph node we could find in this case, like this, like this. Gauze piece spelled jelly. 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 For the beginners, always put in jelly, proper jelly, so that it can lubricate through all this scope. Patient को थोड़ा ऊपर करो. Light. So the same way as you put the bronchoscope, you can see here the vocal cords, the epiglottis, xylocaine. The same technique put xylocaine 2% or 1% randomly to look for local anesthesia to anesthetize this vocal cord. And the same way as we pass through the bronchoscope, here is a little bit difference. Just look at the anterior commissure of the vocal cords and slide down, and you mean the trachea. These are the tracheal rings, and then you can and vascular structure, xylocaine. So here is the corona. You can see this is the right main bronchus, right upper lobe, no growth inside. This is the left bronchus. So first, after visualization, then you can start visualizing from the right side for looking at the small paratracheal lymph node that is mentioned into the. Yes. At the level of corona, just at the level of corona, if you touch the right lateral wall or anterior wall at 3 o'clock position, you can visualize the right paratracheal of 4R lymph nodes. We call 4R lymph nodes from the 12 o'clock anterior to the 3 o'clock on the right paratracheal area. This one, I think, small lymph node. Try to look subterranean area.
So this
This is lymph node, small lymph node. These are the very small lymph nodes. If you put back, this is a small, approximately 1 centimeter of. But it's yeah, it is not looking pathological. It's a sub-centimeter lymph nodes almost. Looking for another lymph node, if we can find better lymph node for demonstration purpose on the coronal area. Yeah, yes, this is having station 7, and this is a large lymph node, approximately 2 centimeter lymph node. And you can see on the your ultrasound images, there is a, on the right side, there is a scale. Without calculating by imaging, you can see this is a more than 2 centimeter lymph node. So here we will try, just put in a local anesthesia first. One moment. Okay. So first we'll rapidly take out the FNA for confirmation of the diagnosis to for the metastasis purpose. So if any lymph nodes on the right side, you have to go to look on the left side of lymph nodes for the staging of the malignancy, the needles. Yes. So we are taking the station 7 lymph node FNS now. It's a very important part for the resection purpose or for the staging of the lung cancers. Middle. Okay. So you can see here I am going from the left bronchus. You can see this station stem lymph node either from the right bronchial tree or from the left side of the corona. So I am in the on the left side of the corona.
Middle.
Till then you can see here.
I don't believe that these lymph nodes are important. What is the diagnosis originally?
This is a CA, right upper lobe.
Right upper lobe.
Yeah.
Why
Right upper
don't you
lobe.
quickly remove it and we see if we can do, because I don't believe you will have any pathology. Are they
Yes.
PET positive?
The PET positive.
Then we can go ahead, because if they are PET positive, then this is okay. The PET positive lymph node in subcarinal area. You can take a biopsy, no problem.
It's always better to pull out the scope if patient is having a little bit desaturation. And don't put suction at that moment and try to maintain saturation of patient around 90 or more than 90%.
We are giving an EBUS Procore biopsy needle because we want to use this EBUS Procore needle for biopsy. So this is So we are trying to take a biopsy for that will be helpful in immunohistochemistry purposes also for this node. Because with the sampling, you need to establish which type of malignancy it
Yeah.
is. Okay. We are not only, because it is a PET positive node, so in this case, instead of FNAC, we are proceeding with a procore biopsy maybe. Okay.
This is, I think, good one. Now, hold it. Or when you put needle inside the scope, always keep this your scope in the neutral position, otherwise it will injure your sheet of the scope, the scope. That is a very costly equipment. So first take out the sheet and visualize the sheet. In the endoscopic image, and little bit, just tip of the sheet should be come out. And first, in the safer side for beginners, you can put your needle, you can calculate around, it should be around 2 centimeter. And just take out the stylet from the needle to sharpen the needle so that you can puncture your total sheet properly. Yeah, this you can see here, and this is the, and after putting the nail, you do this 4 or 5 times this movement to clear the secretions inside the needle by this stylet, and then the first pass should be without section so that there should be no blood. If there is a material is there, then you don't need any section, but you can put section, but every time try to do without section. The first pass should be without section, and in a one lymph node you can pass for 15 to 16 to 18 times, and ideally you should take at least 4 passes from this lymph node, and the puncture should be through and through from one part to other part of the lymph node. So this is the technique, and this is the holding technique. If you can visualize, go slow, pull out slow and go fast, or you can do multiple times this type. Yes. Okay. Let's take out. So we have taken from the station 7 lymph node, this FMSC. Small bleeding is expected from these FMSCs. Yes, very small. These are all acceptable. And take out one more if there is anything. So this is station 7, and you can see the left atrium here. Previously, you have seen very beautifully. And when you turn left side, you can see the Mickey Mouse sign. Previously, we have a large, beautiful lymph node. Here is a small foreign lymph node, but is very not pathological, but definitely subcentimeter lymph nodes. In the 2 lymph nodes, you can see the aorta below on right side, pulmonary artery on the left side, and the small lymph node is 2 lymph nodes are 4L lymph nodes, and they can be seen very beautifully by the EUS examination. So that you can see in the EBUS scope also. So this is a small lymph node. Very interesting, the larger lymph nodes. This one is a good large lymph node at station 7. आया? जल्दी मैं दूसरा ले लेता हूँ, फिर ट्राई देखते हैं, एक को ले लेता हूँ.
So you have shown from the right bronchus.
This is the left bronchus. This is left bronchus.
Can you go into the right bronchus?
Just okay.
Because you've got 3 minutes left.
Okay.
You've got
You can do
the FNAC later, but first show the audience.
Okay.
Because FNAC has already been shown, whatever you want to show.
Okay. Now on from the right side, you can see the subcarinal area. This again you can see here, subterranean, you can see visualize also this lymph node, large lymph node, station 7 lymph node. And this is the below is this is the lymph node. No.
This is the large subcarinal lymph node in the seen from the subcarinal area. So you can see subcarinal node both from the right and left bronchus.
Both sides.
You can go into the right bronchus, you can go into the left bronchus, and you can see subcarinal node. So this is the vessels beyond this, but this is the subcarinal node you want.
Yeah.
So when you go into the right bronchus, rotate
Okay.
anti-clockwise. When you go into the left bronchus, rotate clockwise.
And it's sometimes you find difficulty, always remove this sheet, this needle. इसको करो, आगे कर लो इसको, this tight में करो. And try to take out. And try to take out on the right side. Always this hub should be on the right side of your scope so that easily you can manipulate this length of the needle. Hold it. इसको hold करो. It's very important that your assistant should be very good and he should know where is the lymph node, how to hold the scope. Again, the same step. First, look the tip of the sheath through the endoscopic image of your scope, and then fix the length of the needle and sharpen the needle by taking out the stylet, and then you can pinch your, hold it. Sometimes it's stuck up on the cartilage, then again you have to withdraw the needle and try to make another puncture from the different side. Yeah. And sometimes you can pull, push your scope also to the.
This is called, you push the whole scope along with the needle.
Along the scope too, and sometimes you find difficulty in.
So much of difficulty. Why do you want to do? Go from esophagus. Very friendly. Subcarinal lymph node. Why do you want to do?
Yeah,
But that is
just
just,
this is conference, so it's better to show how to do.
no, why?
Yeah,
You can take it out, go into esophagus.
okay.
Very simply. Okay, why don't you take it out and go from esophagus?
Okay, but Malays take out, and you can see how it easy to by putting through the esophagus.
Okay,
So
now,
this is a very easy technique.
33 centimeters. Don't.
Yeah, just
no, no,
go
no,
down and see if there's the liver.
no.
Okay. Dr. Malays,
Withdraw, 33 centimeters.
okay,
Okay, now,
yeah.
okay.
So this is
Left.
left atrium, mitral valve, beautifully visible, and aortic root, and withdraw.
Just take a minute, and come
Okay,
on.
okay.
So you overshot your time by 3 minutes. So please start the lectures. We will take the FNAC of this lymph node and let you know the result. Thank you.